cervix is a cervix, and all cervix needs care. So perspectives, where do I start from? I had a really formative experience working in Liberia as a medical student. I worked in Nicaragua and Kenya post residency training, and I did do my residency training in Houston, Texas. And then I've also had the opportunity to work as a consultant in several different African countries, and also lived in Nicaragua for a while working. And so I think that as I talk, I bring all those perspectives with me as I think about cervical cancer and the global problem that it is. Now, as we know here, and certainly some of the research coming out of here is pointing to the intergenerational impact of cervical cancer. This is a study that looked at the global estimates of orphans left from women who die of cancer. And you can see that of those in 2020 alone, there were over 1 million orphans from maternal cancers, with 20% of those being from cervical cancer. And we know data shows that without the maternal unit in a family, children have increased anxiety, they marry younger, they're less likely to complete their education and get health care. And so I think we aren't really talking about the generational poverty that this preventable cancer is causing. And we need to think about that because of the implications that just spread far out from that certain person who has cervical cancer. And I was just recently in Nairobi at a conference in November, and I met an individual, a 27-year-old male who had just gotten his bachelor's degrees, the third of 10 children, the first one to go to college ever. And he just gotten this research position, and his mother had just died of cervical cancer. And before she died, she pulled him into the room and she said, "You have to make sure your younger kids get their education and do okay." And so here he was, 27, and now he was responsible for his 6 younger siblings because of cervical cancer. And then this is just another study showing that for every 100 deaths of women at any age, there are 120 orphans. And for every woman who die, 14 to 30 children would die as a result. So again, I think this generational aspect. In the US, which of course is my base, cervical cancer is very expensive. It's estimated at $2.3 billion a year, and the year of death being the most expensive, almost $100,000. And I was trying to find British Columbia data, and this is a little bit old, but the per patient annual cost being $32,000, with the hospital making up 37%. And I think independent of the total amount, what we can all agree on is here we are spending a lot of money taking care of individuals that have a disease that could be prevented. Globally, spending money on cervical cancer is extremely cost effective. And Oxfam did this study where they looked at women's contributions to families and communities and so forth, because we all know that the maternal unit does a lot of work besides that for which she is paid. And if you look at the burden of, or you look at the amount of contributions to the economy from unpaid work, they estimated at 10.8 trillion a year, which is 3 times the size of the global tech industry. So, I think people often ask the question is, can we really afford to do all of these cervical cancer screenings? Do we need treatment places? And I would say, can we afford not to? Look at what we're losing to our economy every year. And then the WHO, when they were getting ready to launch the Global Cervical Cancer Elimination Initiative, did cost effectiveness studies in lower resource settings. And they found that every dollar spent through 2050 for screening would return $3.20 to the economy just based on keeping individuals in the workforce. But then when they added in the unpaid work, it came out to $26 returned to the economy for every dollar spent. And so if we think about our careers as public health professionals, and we think about a 26-to-1 ratio for an intervention, that's pretty phenomenal. In the US, we have this cancer moonshot where the Biden administration, back when Obama was president, started putting a lot of money into this idea of the moonshot for cancer. Like, how are we going to do the research and fund the treatment, et cetera? But it's so interesting about cervical cancers. We have the moonshot, right? I mean, we know what causes it. We know how to find it. We know how to treat it. We even have a vaccine for it. And so this is a cancer that we've solved essentially the science. So now we have to ask, global health wise, why is it still killing a woman every 2 minutes? And globally, in the US, every 2 hours, in Canada, every day, and that the projected cases are only rising. Of course, it's a disease of inequity, and everybody is very familiar with this map where you see the most dense cervical cancer incidence in the dark blue, mostly concentrated in sub-Saharan Africa, not totally. I just do want to draw your attention to this number 29. That's when you get the dark blue. But if you really look closer here at the highest cervical cancer burden, this number of cases per 100,000, like in Swaziland or Eswatini, is 84, and Malawi 68, Zambia 65, etc. And so hidden in that block of dark blue are these pockets of incredibly dense pathology from cervical cancer and incidence. I also show this map of income inequality, and sometimes I put them on the same screen because I think it's not a coincidence that the places where we see the highest cervical cancer burden are also those places that have the lowest income. And another thing that I think is important to keep in context is the HIV burden and cervical cancer. So this is a map that looks at the percentage of cervical cancer cases attributable to women living with HIV. And as we know, HIV is increasing the risk of cervical cancer by 6 times because of a lot of factors, but some of them being how the HPV behaves, progresses faster, has longer persistence, much more difficult to treat with our standard ablation techniques, and also more infections. And so I think in some of these countries down in sub-Saharan Africa, we have 40% of the cervical cancer cases attributable also to women living with HIV. So unless we really battle the dual epidemic, we're not going to make progress on cervical cancer. Now, in Canada, again, this is what I could find as my cases. And it's really interesting that when you search data in Canada, you always get Ogilvy's name coming up on the papers. So I feel like I should just, have done a lit search on Gina and then put her slides in here. But in 2023, about 400 deaths. And that the largest age group being 50 to 54 in this study from 2015 to 2019. And I think what is interesting is this is the same data that we're seeing in a lot of countries, is we had, with the incident when we initiated screening, this really good drop, but now things have just really pretty much leveled off. And so we have to ask ourselves, what is behind that? What's the leveling, and what are we going to do? In the US, we also have a lot of disparities based on geography and states. And here red is the area of the country with the highest incidence, going up to 12.6. If you remember, in sub-Saharan Africa, some of those countries were up to 80. But still, we have a lot of differences. But what's not obvious when you look at this overall map is the racial disparities. So hidden in these US rates, here in the Native American, Alaskan Native, again, we have the incidence rates up to 17.8. With women who are identified as Hispanic, the incidence rates up to 13. And in our country, Black, non-Hispanic up to 11, and then Caucasian up to 9. And so when you look at a map, I think it's really important to ask kind of what's behind the numbers, what's hidden in there, what aren't we seeing when we do this general talk? And if we're going to devise a strategy, how are we going to address these various populations? And then when I, again, was looking in British Columbia, looking at disparities, this is a study that looked at the characteristics of women with invasive cancer. And again, it's a little bit old, but it was, I suspect things might not have changed too much, but you can educate me on that as far as who's the most at risk. And these were the self-identified population groups, and then the standardized ratios for finding cervical cancer. And you can see with Indigenous people having twice the rate. This was using Caucasian as a baseline, and also the geographic challenges, which we certainly see in the US, that the more rural people either could get to a hub or really rural struggle immensely. And when I think about our Alaska population, where, you know, the vast majority of the state, which is a huge state, it's a third of the United States landmass, doesn't even have roads. And so, you know, how we don't even probably know what the incidence of cervical cancer is in a place like Alaska. So, as we all know, we've all seen this slide. We're very excited about this elimination effort. And I was talking last night at a book event about how exciting this was to me personally, because I feel like it was a real statement of faith, in a sense, and also equity, because the WHO has eliminated, like, worked with smallpox, worked with guinea worm. It's working so hard for polio, has not quite reached it. But this is the first time that there was ever an elimination call for a cancer. And the first time it was ever an elimination call for a cancer that just strikes individuals with the cervix. And I thought that this was really bold, because when WHO does their calls, it brings with them so much. And we'll talk a little bit about what it brings with them, and how that gives us hope for moving forward. But as we know, these targets, which we were supposed to reach by 2030, was to have 90% of girls vaccinated by age 15 with the HPV vaccines, 70% of individuals screened twice in the life with a reliable test. So 35 and 45, just twice in your life. And 90% of those who are screened positive or need treatment, getting treatment. And this is actually one of the hugest bottlenecks that we face in the world right now. Now, if we could do all those, even by 2030, we would have had a 30% reduction in mortality by NCDs and be on our way. But of course, they announced this and then COVID hit. So the primary prevention, as we know, is to try to prevent the inciting agent of cervical cancer, which is the HPV and the infection, which causes the vast majority of cervical cancer, depending on what you read, between, as I've read, as low as 93%, but up to 99%. But certainly most cervical cancer is HPV, associated with HPV infections. And globally, HPV 16 is in a class of its own. It's 50% of cervical cancer, with HPV 18 another 20%. And I know we all know that. And I think what's interesting is what is unknown often when I'm talking is throat cancer, that 70% of throat cancer is HPV 16. And actually, in the United States now, we have more people dying of HPV cancers who are male because of throat cancer than we do female, because there's no screening, there's no pap smears, there's, you know, no routine testing for the throat. And so HPV cancers cause a lot of harm, not just cervical. But if you look globally, it's a hugely proportionate to, like, HPV infections is cervical cancer. It is by and far the most common cancer caused by HPV. So in the US, we just use HPV 9. I'm sure that's probably true here. But I do want to talk about other primary HPV preventions, because I think it's important to remember that a lot of the world still does not have access to HPV vaccine. And some people choose not to use it. And so people are like, what can you do? Well, condom use is 60% reduction. Similar to other viral STDs like herpes. It's not 100% because there's still skin-to-skin contact that is not the shaft and the vaginal canal where the HPV can be spread. But also, I think, interestingly, there's, you know, a growing body of evidence about the impact of male circumcision on preventing cervical cancer. And this is a systematic review that was published looking at various studies. As we know, this vertical bar is the line of protection, and we want to be to the left side if we're going to be protective. So here are a lot of studies about cervical cancer showing that male circumcision is protective, and then also pre-cancer. But, you know, I hear a lot about male circumcision as a global public health effort to prevent HIV, but I'm really not hearing that much about intervening on a male to do a circumcision to prevent a cancer in a female. So I would just have us reflect on that difference a little bit. And then this was a modeling study that was done for Tanzania, and they were looking at the impact of male circumcision. And again, it's related to the HIV protection that's offered with male circumcision, from acquiring it and then passing it, et cetera. But the bottom line in this modeling study was by 2070, if they did voluntary male circumcision, it would lower the Tanzanian cervical cancer rates by 28%. So here is another public health intervention that isn't related to vaccine logistics or screening that could really be impactful. And of course, the nice thing about the primary prevention with the vaccine is that we're getting more and more evidence for the long-term protection. In the US, we're still at 2 doses, where we're recommending it 9 to 14 years old. I think British Columbia is still 2 doses too, isn't it? Yeah, it hasn't transitioned. But I do know that this is a very expensive vaccine, remains very expensive. In the US, I just looked up the product label in January and found that it was $286 listed by Merck. And if you think about a vaccine that, you know, has been out for 20 years, made by the same company, and they're still charging $300 a dose, and that, more importantly, we allow that. As a society, we allow them to decide that they can charge $300 a dose. I think it really raises the question of how you approach prevention of cancer. Is it a human rights issue? Is it an economic issue? What framework are you using to bring to bear? So something just happened here. There we go. Now, of course, it works. I mean, talk about a superpower vaccine. You know, we are so excited when the flu vaccine is 60% protective. We just instituted RSV vaccine in pregnant individuals in the United States. 80% protective. So elated that we could decrease hospitalizations for severe RSV in newborns by 80%. Here we have a vaccine that is virtually almost 100% protective against the HPV types that are in the vaccine if we give it at the right time. And this, of course, was the latest data on that. There's been a lot of studies out, but this was in Scotland that came out end of January, that of the individuals who got the HPV vaccine, they started in 2008, and they've been following these people forward because, of course, they have a public health system where they can record things, unlike the United States, and they have been able to show no cervical cancer in these people that got the vaccine. Now, talking about the single dose, I'm not going to go through all these studies, don't worry, but I just want to say that there is a growing body of evidence for the use of the single dose of the HPV vaccine. And I think the initial questions for this started, out of Costa Rica. The initial studies done for licensure used 3 doses. They used them in 18 to 25-year-olds. And in Costa Rica, they were doing the bivalent. And then they went back and looked at the trial and said, okay, it was a really good trial. Most people got 3 doses, but not everybody got the 3 doses. What happened to those individuals? And then they found that, look at the vaccine efficacy. It was very similar in those individuals. Now, again, I just talked about the superpower, 99% effective. Remember, this was 18 to 25-year-olds because this is how we started with a licensure. And so some of these people undoubtedly were carrying HPV by the time they got the vaccine. But the bottom line of this is that the efficacy between the doses was very similar. And then they looked at the antibody titers, and there's been several studies now that show these similar curves, which are, yes, you get higher doses antibodies with 3 doses and 2 doses than you do with a single dose. But what we see here is this flattening of the curve. It's extremely persistent, lasting. This study was through 11 years. And if you look at the natural infection with HPV, this is tenfold higher. So, when we start giving vaccines, we follow the usual, prime boost that we always use with a vaccine, and really are going backwards to ask with this vaccine, do we really have to do that? And I think that we're getting more and more data that is compelling to say maybe we really don't. There was also a study done in India that has a very interesting history. It was a demonstration study where they were giving the vaccine 2 versus 3 doses of the quadrivalent in 2009. And they had the 2-dose group and the 3-dose group. And this study had to get stopped in April 2010. Again, it is very interesting and a tragic story, actually. It was used as a political football, and there were 4 deaths in individuals who'd been vaccinated. And so it got picked up by the media. The trial got stopped immediately. The people for PATH who were working on this demonstration project had to leave the country in a hurry because they were worried for their lives. Well, they had 2 girls in a car wreck. One committed suicide and one was bit by a snake. So they stopped this vaccine trial, and now still in India, which has the highest burden of cervical cancer in the world because of their population, and they have no screening, there's only HPV available in the private sector. And that just came on board in 2018. So a whole generation and a half of individuals have been lost because of the political football of the HPV vaccine. Okay, that's a little side note. The bottom line I was supposed to talk about is that the IARC trial, again, showed that the 3 doses may not be necessary. And they were able, because this trial got abruptly stopped, they were able to look at what happened if they only got the 1 dose. And they, again, saw a very similar vaccine efficacy. Now, there was also, as we know, the prospective randomized trial that's a little bit stronger data because it's prospective and randomized. And that was based in Kenya using a single dose of the nanovalent or the bivalent versus a control group of the meningococcal vaccine. And they were vaccinating individuals that were close to the age of sexual debut, they thought 15 to 20. And they were looking at the HPV persistence of 16 and 18 as their endpoint. And what they found also was that the single dose was highly effective. This was the first release of the data at 18 months. And since then, there's been 3-year data released that shows that it's holding its efficacy. And so what we saw was, just like at this global momentum for a single dose. We do have more efficacy data coming. I'm hoping it might be, I don't know for sure, but I'm hoping perhaps by the big conference that we'll have in Edinburgh in November that we might see some data, but a prospective randomized trial funded by NCI in Costa Rica of 20,000 individuals, 12 to 16, looking at the bivalent versus nanovalent 1 versus 2 doses and doing a lot of really active follow-up. And I'm really hoping that this randomized trial might help countries such as the United States become more on board with moving toward a single dose if it shows that it's promising. So this is just a summary table of the single dose data. And again, I haven't gone through all of these, but there's a lot of studies that come to bear. And so what happened in the WHO actually offered an option. They changed the recommendations and said, you could use a single dose or 2 doses. And what's interesting is the number of countries that have taken up the single dose. It's a growing body. There's actually 34 countries now. I don't have them all listed, but there are some lower resource countries, but there's also like the UK, Ireland, Brazil just came on board. And I think that we're going to see more and more countries moving to a single dose, which we've had some reasons to switch to a single dose besides just logistics and costs that I'll talk about in a little bit. So I find this one of the more hopeful things about the cervical cancer elimination effort globally. Where are we right now? Well, in the Americas, this is the axis here, up to 80% coverage. This is, again, for girls. We're doing pretty decently. We're getting up close to 80s if you look at the average. Europe is an interesting continent. It has a lot of very low resource countries and a lot of very high resource countries. And so its coverage has been mixed, about 50%. Africa is having this big boom. There's a lot of attention going to helping get vaccines funded and into Africa. And Southeast Asia hasn't really moved yet. I'm hopeful that when the Indian HPV vaccine gets into full swing with their production, at least that's the plan, is to use it in the public health sector, and that will bump that. But I do just put this up here. These are the countries that have the national programs. And again, this is the burden of the disease. So you can see that there's still, quite a mismatch. The other thing that I don't know if you talked about in Canada, we did not get any news about this in the United States, even though I was on the ACIP as a representative, about the global supply shortage of HPV vaccine. And so in 2018, there was essentially a manufacturing crisis that happened, as well as a big push to get countries delivering the vaccine who were funded by Gavi. And Gavi is the organization that funds vaccines. It's a public-private partnership. It was a UNICEF spinoff. It's been around for about 20 years. But they've been funding the HPV vaccine to the 52 poorest countries based on GDP since 2012. And around 2016, 17, they had this big push. Let's try to get how many countries we can have to use the HPV vaccine, because, of course, the burden of disease in all that dark area in sub-Saharan Africa, most of those are Gavi eligible countries. So there was a big push in application. There were a lot of applications approved. There was all of this excitement. And then all of a sudden, there was this crash in supply. And so all of these countries that had been planning to roll out the HPV vaccine could not get it. But what's interesting is countries like the United States at the same time, we expanded our age range. We went up to 45. So I was at the ACIP when the person from Merck stood up and was asked about this. It's like, there's this global supply shortage. And he said, we have it covered. Don't worry. We have different pots of how we draw for the vaccine. And, so all the countries that were paying $160 just had no trouble with supply. We could give it to all of our 40-year-old women we want. But if you were a 9-year-old in Ethiopia, you were out of luck because you paid $4.55 for the vaccine. So Gavi did calculations based on what this did to their program. And there were 28 Gavi eligible countries that had to put the brakes on, had their plans in place, had been approved for funding, and just couldn't get the vaccine. And so they estimate that between 2020 to 2025, there are 34 million girls who missed out on the HPV vaccine. So in lower income countries, I just want to remind us, because of the burden of disease, because there's no screening, there's no treatment, essentially you only need to vaccinate 70 girls to save a case of cervical cancer. This is modeling study. And depending on the country you look at and their burden, it might be between as low as 60 up to 90. But the bottom line is you really don't have to vaccinate that many people to save a case of cervical cancer. And so if you just do the math and you divide 70 into 34 million, you'll come up with 485,000 cases, which most of these are lives, because remember, there's very little treatment and prevention. And so at the same time, when we expanded in our country, modeling that the CDC did showed that you have to give 6,500 40-year-olds a vaccine, at least in the United States, to prevent a case, because they've been infected already. We have screening, et cetera. So I just cannot think of a more glaring statement about value of individuals, depending on where they live and how it relates to health economy and the impact on lives lost. So the good news is we have a very rapidly evolving HPV vaccine supply, although, well, I should say rapidly. I wish it were more rapid. But has been a scale up by the countries that have been making it for a while, or the companies. There's 2 vaccines now approved in China, and the Serum Institute in India is very close. I think they're just having a lot of trouble scaling it up. And then, of course, all the vaccine manufacturers got distracted for a few years by COVID. And so, this evolving HPV vaccine supply, it's good news, and it really can't come soon enough. I think that it's also good that the vaccine coverage has increased globally, partly because of the cervical cancer elimination effort. There has been a big push post-COVID to get the ships righted with this vaccine. And when I interviewed Kate O'Brien, who's the head of immunizations at WHO for my book, she was saying that of all the vaccines recommended by WHO, it's measles and HPV that save the most lives. So those are the two programs that they just really, really, really want to get back going, doing better post-COVID. And it is doing a lot better. 20% now of girls globally have had a dose, which is up from 15% pre-pandemic, down to a low of 13% in the pandemic. So there is some recovery going on. There's a lot of renewed efforts. Gavi now is funding not just those 52 poorest countries, but also countries that recently graduated. That is like their GDP bumped up just enough. Like Nigeria was one of those, to where they don't completely qualify, but now they're giving them funding. But I think the hardest still are the countries in the middle. Like I've worked a lot in Namibia. And if you look on paper, they don't qualify for any of this aid. But, it's like a lower income country, and they can't get the HPV vaccine. And the best deal they could negotiate was $19 a dose. And so they have the plans in place, but they still haven't pulled the trigger. And they have a really high HIV burden. So there's a lot of cervical cancer in Namibia. But I call these like the caught in the middle countries. And I think that is really where we're not getting the global public health attention of how are these countries ever going to get access to this vaccine. So where are we in the US? Again, our country is so varied, depending on where you live. Here, dark blue is higher coverage. So we do have some good news pockets here where we're up to about 90%. And for instance, in Rhode Island, it's the only state that mandates the vaccine and gives it in schools. And they have 95% coverage. But what's also interesting about this vaccine in our country is it's the opposite of what we usually see with socioeconomic impact. Those people living above poverty have lower coverage with the HPV vaccine than the people below poverty. We can talk a lot about why that would be, but it's certainly not true for most health interventions. And racially, it's also the opposite. Like Caucasians have the lowest uptake of this vaccine compared to other population groups in our country, except for the uninsured. So I think that there's a lot to be said about the story of that and how that's happened and what we need to try to continue to work on. But it has created quite a legacy in our country of many individuals who have not been vaccinated. And we're seeing the deficits of that, which I'll show you in a minute. This was, again, what I looked up for British Columbia. And it looks pretty good here, you guys, like 70%, really stable. Again, how do you get high? This is COVID. So when you have a school-based program, of course, you expect this. And then this is the various health authorities and the coverage, again, pretty even. So, the question remains, how do you bump up past 70, right? I mean, how are we high income countries that are not meeting the WHO targets going to get there, besides moving to Sweden? I would say that in the United States, we don't do vaccines in schools, most places, because, you wouldn't want anyone to give your students advice besides the parents. And so it's been a real challenge, but there have been a few places that have tried this. The Rio Grande Valley is in south part, borders with Mexico. It's very high immigrant population and has practically no cervical cancer screening for low income people. So the HPV vaccine is super important. There was an investigator that lives in Houston or in Galveston who did the study where she randomized middle schools. And she gave the 3 middle schools, they all got the same education, which was really a broad-based education to the medical providers, the public health people, the parents, the students, et cetera. But one of those schools, they offered on-site vaccination. And of course, that school had a 3.6 times increase in vaccination compared to the other two, even though they all got all the same information. So I think you just can't, it's just hard to argue that if, school-based vaccination isn't useful for delivering the HPV vaccine. I would say that there is some really importance in this vaccine because of it being transmitted by a sexually transmitted disease for culturally relevant messaging and what can work. And we certainly made so many mistakes in our country when it was rolled out. But there are some really fun stories out there about people who have done creative things with messaging. This is one from the Arizona's Navajo Nation, where they combine the HPV vaccination with a coming of age ceremony that is very traditional and really important in their culture. When an individual gets her first period, you know, the aunties, the grandma, the mom, they all come together. It's this wonderful celebration, and they combined HPV education for screening for the older women as well as vaccination, and they got 82% coverage. And again, in our country, you know, the burden of disease of cervical cancer in Native Americans is twice what it is in Caucasians. And so I just felt like really encouraged by this. Okay, what about secondary prevention screening? I won't dwell on this much because I know the United States is a little bit different and you guys are ahead of the curve with screening, but we still have two different recommendations going head to head in our country. We have the American College of OB-GYN and U.S. Preventative Task Force that say, you know, use cytology alone for until you're 30, and then use either cytology or FDA-approved primary HPV test or co-testing from 30 to 65. Everybody's saying stop at 65, which I'll speak to in a minute. And then the American Cancer Society, which is saying start screening at 25 with an HPV test. Do it every 5 years through 65. However, everybody's trying to play in the sandbox and say that what's most important is no matter what test you use a test and get screened. But I do want to speak to the power of the negative HPV test, which I don't have to tell you because you have Dr. Ogilvie, who did research, who showed us the power of the HPV test in the HPV focal trial and has been one of the formative studies globally for moving to HPV testing. But I do like to tell the residents about this just because I think the negative predictive value of an HPV test in routine screening, not when you're surveilling someone who's been treated, is just crazy good. You know, way less than 1% risk of cancer in the next 5 years. And it's hard to imagine a screening test that's better than that. And so I think that there is a lot of room to move toward HPV-based testing. And in the US, one of the controversies remains 21 to 24. Do you offer any screening to 21 to 24 here? So you did it. But see, you've had better HPV vaccine coverage for longer. So I think what we decided to do with our residents was they were like, okay, you guys get together and decide what you're going to do. And so essentially what we do is we talk to our patients 21 to 24. If they've had the HPV vaccine, you know, say you may be better you can wait till you're 25 if you want, or if they haven't, can offer PAP screening at 21. I think we still don't completely uniformly know what to do. But some people who've been without the vaccine and have been sexually active for a decade, by the time they're 21 or 22, 23, people are nervous not to screen them. And then the screening stop at 65, I think you're 70 here. It's a little problematic. 20% of our cases of cervical cancer in the US are in women over 60. And I think that it's because we're missing the postmenopausal age group for screening. And it looks like that's true in the Canadian data too, where you have a large portion of women getting not screened in cervical cancer, you know, at that age. And I feel like, you know, you only stop screening if you've had negative tests before then, but not just because you turn the age. And I personally, in my clinic, have had trouble ordering a screen over 65 because Epic, our electronic medical record, has this hard stop, you know, and I have to get waivers to order a test after 65. And so it's a lot of work. And I think that is something that was based on expert opinion more than prospective trials or knowledge. And it's really not being represented well as far as stopping at 65. Everybody agrees to get screened, and everybody, whatever country you're looking at, high resource countries that's offering screening, we're seeing this drop in screening. I was just in England. They used to have 85% coverage. Now they're down to 70. And so I think that there's also harm with people not getting their annual exam every year. I agree that we don't need the annual exam every year, but it's also important to realize that there was something nice about people coming every year. Okay, I think I somehow got off my slides here, so let me get back. Here we are. Okay. So where are we in the world? This is one-time screen once in your life, 30 to 49, and red means you haven't had much screening. So if you look globally at where we are with screening, it isn't so good for reaching the WHO objectives. And again, India has only 2% of people screened and the highest burden of cervical cancer. In the US, again, ours is very varied. And there's pockets in here. And what's hidden in here, for instance, from my research for my book, the Rio Grande Valley, 10% of low-income women getting screened. And so we really have challenges between an urban-rural divide. Low-cost screening in our country is really problematic. Low-cost screening, meaning that people can get either an HPV test or a pap smear without having to pay for it, depends on your insurance. And in our country, the public insurance option is Medicaid. And how much Medicaid funding you have and what income level you can go up to offer Medicaid depends on the state, because states get to decide if they were going to take advantage of the federal program to expand Medicaid. So for instance, in the state of Washington, if you're a family of 4, you can make $38,000 a year and qualify for Medicaid. If you're in Texas, you can make $4,000 a year and qualify for Medicaid, which is like living in Namibia. And so the low-cost screening options, sometimes there's been Planned Parenthoods or community health centers, but those have been closed in a lot of our country because of the war on reproductive health rights. And so we really have a crisis of being able to screen, and especially doing the colposcopy, biopsies, and the follow-up treatment, which even if you have CDC funding for low-cost screening, they don't pay for that part of the evaluation usually. So we have people getting $3,000 bills for their colposcopies, their biopsies, their leaps, et cetera, and no way to pay for it. So I just feel like this is this big crisis that really isn't being talked about enough right now. And the other thing I would just say, and I know BC is spread out too, what do we ask individuals for cervical cancer treatment? The number of visits, the transportation, the providers they have to get to, the shortage. And so I think we really have to stop and think, yes, we can prevent cervical cancer, but the secondary prevention, the screening and the treatment for the pre-invasive disease, we are asking a lot of our healthcare systems, and we're asking a lot of our patients to really get them to do this well. And so that's why I think your innovative approach to the self-sampling is really exciting. So here is just what I could see for the BC screening rates. And again, a population, if you get rid of people who've had hysterectomies, is up around 70%, which is what the US is as well, if you average everybody together. And then, of course, this new self-screening kit, that's so exciting. And congratulations. We were just talking beforehand, the 20 years of work that went into this mailing that went out. And also the infrastructure to follow up. And in the US, this is not FDA approved yet. And I think there's a few reasons. Number one is 20% of the United States doesn't have the lab support to cover primary HPV testing, especially in the rural areas. So that's a big problem. And secondly, we don't have the ability to really follow people very well or track them very well. And so I mean, we don't have FDA approval yet, but there are studies going on. Again, I said this at the beginning, but a cervix is a cervix. pretty much every study you look at for individuals who do not identify as cisgender women, that the screening rates are lower. And of course, that makes sense. And I know at the Harborview, the clinic I work, we've started having Tuesday afternoons as a time to offer screening when we might have more individuals that don't identify as female in our waiting room, et cetera, to offer screening, just so people can, see other people that might look like them. But it's a very big challenge. And this was a large Toronto study that found the same thing. We also had redlining in our country. Do you know what I mean by redlining? So essentially, redlining is just what it was said in post-World War II, when people were moving into buying houses more. Literally, red lines were drawn across cities, and people who were of non-Caucasian backgrounds and sometimes non-Protestant backgrounds were not able to buy houses in certain neighborhoods because they couldn't get loans, or the realtors wouldn't show them those houses or whatever. It wasn't always completely obvious, but the systems were in place and super powerful. And so we have, for instance, in Seattle, the Ship Canal Bridge, which is, goes University of Washington out, was redlined. We have very few people of color living in the Seattle city limits north of that. They live south of that. And cities across the United States are very similar as far as this redlining. But again, if you look at the intergenerational impact of these decisions, you see it. It's very obvious. And here's a study that looked at the impact of redlining on various cancer screenings, including cervical cancer, that the odds of meeting this national screening for cervical cancer was 79% less likely if you lived in an area that was redlined. And there's all kinds of socioeconomic health access reasons for that. But I just think that unless we start really talking about that and owning that, the chances of really working toward it, resolving it, are less. I talked about Medicaid expansion. I think one of the things important is to say, do we actually have data that shows people are getting less screening in these states? Because if you think about how this will get changed, this will only get changed if the state legislatures themselves vote to change it, which will only get changed if the people in the state say, we've had it. We want better health care. And so the answer is there is less PAP tests in the expansion states, and the uninsured women in these states even more fall behind. So what is the result in our country? The result is we have an increase in stage 4 cervical cancer being diagnosed in the US, in the South, an increase. And this is stage 4, right? This is the 17% survival rate cancer stage. And although, of course, in our country, women of color still have higher cervical cancer overall, no doubt about it. But if you look at where the increasing rates of advanced cancer is, it's white women in the South, 40 to 44. 4.5% annual increase in stage 4 cancer because they have not gotten appropriate screening, because you can't get it if you don't have money. And they were teens when the HPV vaccine uptake was 13% in their population group. So they had adults above them, or whoever, their church, whoever, making these decisions that they didn't need the HPV vaccine. And now they've aged into cervical cancer and they're getting it. And so again, this is one of those awful things that we're seeing coming to bear about what happens if you think about your prevention as a socio-political thing instead of a health intervention. So one of the things I've started thinking about is how can we ask what it means to those who have cervixes to get this prevention? Because HPV is a sexually transmitted disease. We're testing for it. It still carries stigma. How can we work with the populations we're serving to try to help this be more successful? And, Gina mentioned I did this book recently where I curated stories of cervical cancer survivors or family members from 6 continents. I did multiple hours of interviews and I interviewed a lot of experts. And I wrote this book that adds evidence-based information behind it. But here's some of the things that I think about that came from those interviews. If we think about the intangible obstacles to cervical cancer elimination, we've just talked about the tangible ones, like getting a screening test to people or getting the results. But stigma, which a mark of disgrace associated with particular circumstance, patriarchy, a system that values the women and the health of women and the money put toward the health of women more than the health of men more than women. Child marriage, if you look at that African map, I have a map in my book that overlaps child marriage under 15 with cervical cancer. It's the same map. How do you have agency for yourself and your decisions when you're married off at 15? And then, of course, the burden of unpaid labor. So I think these are other obstacles to cervical cancer to talk about. And these are just some thing that really struck me when I was interviewing women of all socioeconomic strata. It didn't matter the country. They all talked about being stigmatized for having cervical cancer. And one of them, this was from a woman in the Czech Republic who said, it's like a sticker, my little sticker that says I'm promiscuous. And all of her friends have said things to her like, you only have cervical cancer because you had too many partners. And this was a woman who got diagnosed when she was 25, who then said, the moment I got asked if I'd been tested for HIV because I had cervical cancer, that was the moment I decided not to talk about it anymore. Am I at fault? I'm at fault for HPV, but my partner, well, he does not have the same social consequences. And anyway, these are just things that were said. In India, it's very common for the mother-in-laws to tell their daughter-in-laws they can't get screened because they themselves were never screened and they shouldn't get screened. So where do we go? I think we move toward advocacy. And I think that, we have some stories that are encouraging about advocacy. In the US, we changed HIV treatment care. In Ireland, they changed their abortion laws. We just had this big cancer moonshot cervical cancer forum in January. I was so excited. I was kind of geeking out that I got to go. And you just kind of wonder what will happen with that. But what was exciting about that was the equity discussion was on the table. And we have not bumped our cervical cancer rates in 30 years, screening rates. Again, I mentioned the 20% of still doing PAPs because they can't transition to HPV testing. So we look forward to the next steps from this. I'm getting low on time, so I won't go into the partnerships for funding for women living with HIV, but it is exciting that there's a lot of money going in now to screening in Africa and treatment for women living with HIV. PEPFAR has a $7 million budget, but I just do want to draw attention to this. Of the $7 million, only $18 million is being spent on cervical cancer. And I just showed you the burden of disease, showed you the interrelationship. So why is such a small percentage being spent on cervical cancer prevention when the diseases are so interrelated? And how will the pot get bigger? And I think this is another thing when we really have to look at advocacy. And so I am searching for new advocacy partners. I'm looking forward to this part of my career that's coming up about using the power of stories to talk more about impact. And I would just encourage all of us to think about the stories we have. We all have our stories in our peer group. And together, I think we just have to keep going, that we can do this. Thank you.
So I know we don't have a lot of time. So Rebecca, who's watching are there any questions online? Rebecca? Not yet. Not yet? Okay. Any questions? Maybe we have time for one question in the audience. Anything?
I'm sorry, I talked so long.
No, it's great. And just introduce yourself as well.
Hi, I'm Anjali. I'm wondering about your slide on, in the US that screening rates are actually higher among lower socioeconomic status individuals and populations. And I'm just wondering, what particular factors do you hypothesize might contribute to that?
So thank you for that question. It's actually vaccine rates. Oh, sorry. Yeah. And so I think that I guess the bottom line is that the white Caucasian population was really influenced by the religious right when this vaccine rolled out. Focus on the family, and the Catholic groups in the United States came out against it, said don't vaccinate your kids. It's just a way for them to become promiscuous. Pediatricians were of similar mindset, advised against it. And so it became a statement of behavior versus a cancer prevention vaccine. So it's taken a long time to recover from that. We are working on that. But I do think that the non-Caucasian groups didn't have that same influence telling them not to vaccinate their children, that it would lead to bad behaviors.
So, sorry, do you have one?
There's just one question from Zoom from AirZoo. One question that frequently arises from our HPV research participants is whether there's any data regarding the effectiveness of the vaccine in clearing pre-vaccine infections.
Thank you for that. That's a hard question. I would say that in the United States, actually, American College of OB-GYN just has recommended that people getting treated with a LEEP, if they haven't had the vaccine, get the vaccine. The question is it going to prevent reinfection, or is it going to help your own antibody response locally? When you boost your serum antibodies, are you going to get more at the mucosa that actually helps prevent progression? It's probably not going to shut off the virus. And so I think that biologically, that's a really difficult question, and we don't have super great prospective definitive trials. People here might have their own opinions and know that too. I mean, I know you guys know the data well.
Yeah, I think we agree that there's some data that shows it's.
And we vaccinated.
Yeah, and we vaccinated.
Yeah.
But we'd prefer they get vaccinated before.
Yes. Yeah.
It's cool. Get vaccinated. Alrighty, here I'll
Okay.
So again, let's just take a moment to thank Dr. Eckert for a tremendous presentation and just really highlighting the role of advocacy, storytelling, and she's very modest about it, but she's got a great book. We've got 4 copies in our office, so for folks who want to borrow them, and we've got Deborah, who's heading the Department of O&G, and Chelsea here. I often think it would be a great thing to give to residents, to training midwives, as a welcome, because it's just a really marvelous example of advocacy and telling stories and how they intermix with the science and policy. So it's a really great read. So thanks again for coming up, and we hope to see you again soon.
Yeah,
Okay.
Thank you. Thank you.